doing the colposcopy, and then the colposcopy would proceed to a diagnostic excisional procedure. This is different than on the other side of the algorithm, in that no longer would it be acceptable to do ablation. We would not want to do cryotherapy when we can't see the full extent of the lesion. I had shown you some data yesterday that if the lesion extends into the canal more than 5 millimeters, somewhere between 2 and 7% of those women may have invasive disease in the canal that we cannot see. And so the loop excision procedure gives us a way not only to treat this lesion, but also to rule out an invasive disease process that's above what we can safely identify with colposcopy. Follow-up after that is quite similar. We would do our co-testing at 12 and 24 months. As long as results remain normal, she goes back into the routine screening pathway. If any result is abnormal, then she should again undergo colposcopy. Another situation would be patients in whom a Pap test shows a high-grade squamous intraepithelial lesion. And so again, we're immediately worried that she could have a precancer. But sometimes when we do our colposcopy, there is no visible lesion to explain the severity of the abnormal Pap test. Now this could be for a number of reasons. One is that even though colposcopy is a good test, a patient could have a very small lesion somewhere in here that we just miss because we can't see it. The other is from my talk that I gave earlier this morning, perhaps the lesion is in the vagina or even on the vulva, and that this could sometimes cause the Pap test to be abnormal when the lesion in fact is not on the cervix at all. So how should we manage? This is an algorithm for management of patients where we have discordance, where the Pap test is concerning, but the colposcopy does not support it. So our various options could include doing co-testing at 12 and 24 months. So what we're essentially saying is that the colposcopy has ruled out an invasive cancer. We see nothing that is that severe. And so that if we do co-testing at 12 and 24 months, we're allowing for a lesion to regress, but we're also saying that if there is something there that's real and it progresses, that those two co-tests at 12 and 24 months should detect it again so that we would know to proceed back into colposcopy. An alternative approach that is acceptable would be to say, well, we have a high-grade Pap and we don't have a visible lesion to account for that. We could do a diagnostic excisional procedure. This approach has the advantage of being very thorough. What we would be ruling out by doing this is whether she has dysplasia perhaps in the depth of a gland cleft where we couldn't see it on the surface.